Hello, I'm Dr. Daniel Griffin.
And I'm Dixon DePalmier.
And today we're going to be discussing heart attacks or acute myocardial infarction. This is another one of those non-communicable diseases that is a significant issue throughout the entire world. We've discussed that cardiovascular disease, strokes, and heart attacks are currently the number one killer worldwide, with cancer nipping at the heels, so to speak. So this is going to be a major issue. What is a heart attack? What is a myocardial infarction?
Are you asking me, or this is a rhetorical question?
I think it's rhetorical.
It's okay.
we'll go with rhetorical.
Then he's going to give you the answer.
So I'm going to give you the answer. It's damage to the heart muscle due to either inadequate blood supply relative to demand.
Exactly.
So it can be the blood's not getting there, or the demand exceeds the amount of blood that is being demanded. So this is much like stroke, where there can be a blockage that prevents it from getting there. Right. And the current thinking, and this took a long time for people to sort out, is that there's a narrowing in one of the vessels supplying the heart, and there's a plaque. That plaque ruptures, and then you get acute blockage right there. And that's our classic thinking of what causes most classic heart attacks. Now, there are certain times when someone might be ill where the heart might be having an increased demand. Can you think of any situations where a person might be so ill that they're... Okay, I thought you would be able to.
Well, when you up the metabolic rate by fever, for instance, which increases the rate of enzymatic activity and metabolism, that might be one situation where there's an extra demand on the heart.
Yep.
Am I right?
That is perfect. And
okay.
A lot of times someone who is acutely ill, maybe they're so severely ill that they're septic, they may actually end up with a combination of a demand and a poor supply relative to that demand, which can actually result in myocardial damage. It's a little bit different than the classic heart attack we think of, where there's one particular blood vessel, that one is blocked, we get a localized bit of damage to the heart. But no, there are demand relative to supply situations where there's myocardial or heart damage.
Right.
And we want to make a distinction between myocardial infarctions and sudden cardiac death due to an arrhythmia, due to a electrical disturbance.
Interesting.
Which is still a major cause of death throughout the world. So I want to make sure even though we're talking about heart disease, right here we're specifically talking about myocardial or cardiac ischemia.
Right. I think when you reduce the oxygen content of your blood, when you smoke cigarettes,
that can be a problem.
Which reduces the ability of the blood to actually absorb oxygen, because you've produced carbon monoxide as part of the smoke syndrome, which replaces the oxygen molecule in the heme portion of blood. And that, I've studied this a little bit because, from personal experience, my father died of a heart attack. So I wanted to know some of the mechanisms involved. But it's also a syndrome that most smokers are unfortunately faced with. They have a reduced oxygen capacity because they're limiting themselves in that particular way. So that might be another example of why there's so much heart attack.
And in the acute, people think, I'm going to give up smoking. Every time you smoke a cigarette, you're actually destabilizing those plaques and putting yourself at an increased risk of a heart attack right then while you're having your cigarettes. So let's talk about the clinical disease. I think a lot of people are familiar with the clinical presentation of an acute heart attack. And this I'll let you sort of describe, and then we'll have a dialogue about this.
We will. I've asked people what it felt like for the early onset. What was the tip-off that you were suddenly suffering from something more serious than just indigestion, which is what a lot of people thought it was when it started. But then it's described as someone that's placing a tremendous amount of weight on your chest. It feels like a weight rather than a pain. It's just very difficult to breathe. and you're short of breath, and all of a sudden, then I've also heard, of course, that you get pain in either arm. It shoots down the sides of the arm. And then after that, then it develops into a full-blown attack.
So this is great because I think you touched on a lot of the points that we want to get when we're getting our history. So one of the first things that people will present with is chest pain. We say chest pain, but then as you describe it, when we say by pain, can you describe the quality of the pain? And people use various words. They might say sharp. Sharp for some people means severe. Sharp for other people is like a knife.
Of course.
The quality of the pain of a heart attack is a pressure or a squeezing, something like an elephant stepping on my chest. So the quality. The next thing we ask about, and this is just good for all sort of pain, is location.
Right.
And the location with heart attack associated pain is usually in the
It's got to be in the chest.
yeah,
right?
it's usually in the chest. It's usually in the left side.
Right.
Occasionally it can be in the right side,
Yeah.
which interesting enough has a higher predictive value, which
Huh.
seems a little surprising to a lot of people. In addition to the pain, there might be radiation. People may say, I feel the pain, the pressure, but it's radiating either down the arm or up into the neck. And again, it may radiate to the right arm, which is less common, but again, more predictive.
Wow.
We might also ask about the quality of the pain, as far as is this a mild pain that you can ignore, or is this a severe pain? So we might use our pain scale that we talk about in our section on pain.
I was actually thinking about
And usually people will present with a high level of pain associated when they're having a heart attack.
that. What about shortness of breath?
So talk about associated symptoms. So shortness of breath, they feel like they can't get enough air. They might become diaphoretic. They might break out in a sweat. They might start to feel emotional reactions. They may feel a sense of dread or doom. They may feel anxious. There's a whole emotional part that comes along with having this, which is a slight bit different. People say they break a leg, or there usually isn't a sense of impending doom. But quite often with a heart attack, there could be a sense of anxiousness, of impending doom, of this is the big one. I'm not going to survive this. So there's a whole aspect to the presentation.
There is a lighter note to this, of course, and that it results from an incident that actually the comedian Carl Reiner went through. He had a heart attack, and he had it in the middle of the street. I think he was in Hollywood, but I'm not sure where this happened. But it happened on a crowded street, and he's describing this on a late night show sometime later. And he said, I was totally unprepared for this. He said, I fell down on the sidewalk on my back, and there I was, and some kind gentleman came along and removed my jacket and rolled it up and put it up underneath my neck as a pillow. And at the same time, he asked me if I was comfortable. And I responded to him at the time. He says, I make a good living. Can you imagine? You're dying, right? And the last thing you can think of is telling a joke. And that was
I think a comedian to the core.
That was Carl Reiner.
To the core.
I make a good living. Most people wouldn't go down that route.
So, but I will throw. We presented the classic presentation, but we believe that as much as a third of heart attacks are silent. They occur, people don't know, and they're later diagnosed.
Isn't that interesting?
And particularly in women, you can have less classic presentations.
Is that right?
So this is perfect if they come in with all these classic presentations.
Wow.
But you don't want to drop your sensitivity to the point that you're going to miss we'll call it atypical. We'll call it a heart attack that does not present with all the classic symptoms.
Got it.
So the next thing that we're going to throw in is we've got our clinical presentation, our symptoms.
Mm-hmm.
We also have our exam. So a couple things that we may notice on our exam.
Sure.
As we start to examine the person, sort of moving down, You may actually see elevation of the jugular venous pressure, looking at the neck. You may, when you listen to the heart, you may hear a gallop. You may hear a extra heart sound. You may actually hear a new onset murmur if it's affecting an area of the heart, which is related to valvular function.
Yeah.
You may hear crackles in the bases of the lungs if they're having an issue with higher
Fluids.
higher pressures, and so
Yeah.
you're having fluid.
Pleural effusions? Is it called?
Pleural effusion would be the fluid around the lungs.
Oh, okay.
Takes a little longer to develop, would be a decreased, but this would be fluid pulmonary edema.
Got it.
This would be crackles in the bases.
Got it.
So there will be findings on exam as well. One of the mainstays, though, is going to be your electrocardiogram,
Absolutely.
which you think, a lot of these areas of the world may or may not have. But I'm going to say that this is another one of those technologies which is becoming more accessible to many people in the world.
That's right.
The rhythm strips, they now have these tiny rhythm strips that could fit in your pocket, and they're about there, they're about that high,
Wow.
and they're a thickness of a few sheets of paper.
Oh,
And these often work with the smartphones that people carry with them.
that's great.
For the full, as we say, 12 lead or multi-lead EKGs, you may require a slightly larger machine, but the machines are getting smaller. And when we talk about the fact that this is one of the major causes of death throughout the world, this is another thing you should think about when you're going to be practicing.
Sure.
Can I have at least a rhythm strip?
Yep.
But even better, can I have a multi-lead or perhaps a 12-lead electrocardiogram?
Exactly.
Why do we want to make this diagnosis so quick?
Because probably there's something you can do during a short window of time that you can't do if you waited a little bit longer.
Now, I know when you and I were talking sort of off screen,
By the
occasionally
way, that was just a guess.
occasionally we talk when we're not recording videos, and you were saying a stroke is a heart attack of the brain.
Well, that's what I've been told.
And I guess what we could say, a heart attack is a stroke of the heart.
That's right.
It's one way to spin it.
A stroke of bad luck is the best way to put it.
But it's the same idea that we have about urgency, that time is myocardium. Time is heart muscle.
Okay.
And so the more time goes by without doing what you might do to reverse this process,
Right.
the more heart damage will result.
Absolutely.
So we're going to talk a little bit about what we can do acutely during that time, and then we'll move on to what do we do secondarily. What do we do after the fact, or what do we do hopefully to prevent these from happening? So acutely, someone comes in, we talked about you've got a plaque which has ruptured and now closed. So you can think of, if you're a plumber, what would you like to do? Would you like to sort of ream that out, maybe push a wire through and open that up?
You know, I've got some prior knowledge on this. I don't want to spoil your story.
No, please go
Well,
ahead.
you could insert a device called a stent, which then it's collapsed when you insert it, and then as you withdraw the instrument that you inserted it with, it's like a mesh of expandable material, and it sort of widens the lumen of the closed vessel. And I know someone who's had several of those stents put in place. A balloon is another approach. You could actually insert a deflated rubber object, which you would call a balloon, I guess, and then on the plaque itself, you inflate the balloon to push pressure to actually push the plaque back where it used to be. That seems a little cavalier, because if you push it back, what's to prevent it, after you withdraw the balloon, from doing the same thing again?
Yeah, so I guess we'll talk about
I like the stent better because it stays there.
Well, we'll talk about this.
But the big deal there is,
Because actually they're ultimately going to be the same process. What you're going to be doing in these, we'll call them cardiac centers. There usually will be centers that are angioplasty or acute myocardial infarction centers.
right.
And usually a region will hopefully work together to have a specific center where people are sent.
Yep.
And part of being one of these centers is having the ability to accomplish this within a window of opportunity.
Okay.
And the window of opportunity for revascularization, for opening up one of these areas, is going to be even smaller than it is for a stroke. So you want to, hopefully we talk about door to angioplasty or door to open vessel being less than 90 minutes is ideal.
That's pretty quick.
And so what they'll do, and you have two approaches here. One is mechanical opening of a restricted area, and they will pass a catheter, usually through the groin, sometimes through the arm, and this small catheter will then actually be fed up into the coronary vessel. You'll actually pass a wire through this occluded area or the narrowed area, and then you're going to advance the catheter, and either it will be a naked balloon, which will expand, or there will be a stent, which is being expanded by that balloon. And there's different situations where you will either put in a naked stent, a drug-coated stent, or when you're inflating the balloon, you're not so much pushing it to the side, you're cracking open, so you now have an area for it to pass through. And it's interesting because the stents can be quite expensive, and they require long-term medications afterwards, so that if you do it, you're then committed to medication for a period of time afterwards.
You don't want a clot developing on the inner surface of the stent,
clot, as
right?
you mentioned, could develop right there.
Sure, absolutely.
There are centers where they don't have the mechanical intervention, where again, they're going to use thrombolytic therapy. They'll actually say, we're not going to be able to get someone to one of these centers in time. And so they may be using our thrombolytic medications, putting that in, as long as the person doesn't have contraindications, high bleeding risk, and just dissolving, lysing open that clot that is formed.
Right.
In addition to those, which I'll call like our primary therapies, hopefully in our cardiac centers, antiplatelet medicines, aspirin, but also some more advanced ones that we now have available. But then there's all the other things that we can do either with or without our acute mechanical or chemical interventions. And these have been used for many, many years. So nitrates. So
nitroglycerin.
Nitroglycerin, exactly. And that can be applied as a paste. It can be taken as a pill. It can be run in intravenously.
What is the mechanism of that, just in passing?
It works. It's the nitric oxide effect. So it's actually directly working on the vascular muscle. And one of the nice things, if you're in an area where resources maybe are a little bit limited, you may use the nitroglycerin paste, which you can titrate to effect and titrate to your blood pressure goals.
I'll be darned.
So you may use 1/4 inch, you may go up to 2 inches, and you may just adjust that as needed. Beta blockers slow down the heart, decrease demand.
Right.
In some settings, and hopefully people have, as we mentioned, this could be a severe pain. Morphine can help both with pain, and it can also help with the hemodynamics. So there can be benefits there. Sometimes we'll even use Lasix or furosemide,
Right, that's a diuretic.
which is a diuretic, but also has direct effects, vasodilatory effects.
Sure. So when the heart is damaged by the loss of a blood supply to a certain area of the heart and it's compromised, does the heart have the ability to repair that if the blood supply is renewed, or is that muscle tissue gone forever?
If you can get within this window of opportunity, if you can save the myocardium within your 90 minutes, a lot of times you can actually preserve the myocardium.
You can.
If you are delayed, or if you can't, not only is there the area that is affected where you can have permanent, we're going to talk about what we mean by permanent, but you can even have a watershed area around the acute event which can become damaged. But yeah, what about, does it just heal? You
need some stem cells for that, don't you?
It's actually interesting, and this will be sort of more, I'll say, an advanced aside.
Right.
But you asked the question. I think it's a good one. When I was training, I was having a bit of issues with authority, so to speak.
Oh,
so
really?
they asked one of the other
I would have never guessed.
one of the other trainees, Bill Lombardi, to work with me.
Right.
And Bill went on to pioneer, at least in the United States, an intervention for chronic total occluded coronary vessels, where someone would come in and the vessel was closed, the myocardium was felt to be unsalvageable because there was no blood supply, and he started opening these up and actually showing improvements. So the pessimism was not completely warranted. if you establish the blood supply, maybe you can get this back. And a colleague of mine who was the best man at my wedding, he's now doing it in Colorado, and this is spreading.
Wow.
Yeah, so there are, we'll say, advanced, more resource-rich approaches.
So there are 5 coronary arteries. I've been led to believe this.
So we're not going to go there because we're going to be trying to finish this up in 20 minutes, even though we could probably talk about heart disease forever. And I just want to make sure we talk about chronic secondary prevention.
Great.
So someone has had it, or they haven't had it, and we'll just make sure we go through the list, which is going to be very similar to almost just good advice in general. If the person has had a heart attack or is at high risk, we might consider antiplatelet therapy, so aspirin. If someone has hypertension or has had a heart attack, beta blockers can help with secondary prevention. Blood pressure control, both in primary and secondary prevention. Diabetes, we want to have that well controlled. Don't smoke. Cholesterol, you want to look at controlling your cholesterol. Weight loss and diet changes and increased physical activity. And then if the heart damage is significant and we have congestive heart failure, then we're going to be discussing how we might approach that and different therapies that can not only manage the hemodynamic aspects that may actually also lead to healing of damaged myocardium. All right, well, I think that was a pretty big topic, and so we look forward to seeing you again.
See you again next time.